Good evening, Shrujana ma'am.
Hi, good evening.
Good evening, Gautam sir.
Good evening. How are you?
Fine, sir. How are you?
I'm fine. Who is the first speaker?
Sir, Dr. Siddharth.
Okay. How many members have joined totally?
Sir, now it's 22. It will increase.
Okay. Right. Thank you.
Thank you, sir. Good evening, Jovita ma'am.
You're able to hear me now?
Yes, ma'am. Good evening, ma'am.
Yeah. Am I visible?
Yes, ma'am.
All right. Can I just share my slides to see if it is displayed right?
Yes, ma'am.
All
Yes,
right.
ma'am. Yes, ma'am.
Can you mute me? I mean, like, I'm not able to mute. None of it is working actually.
Ma'am, there's an option share screen below. Yes, ma'am. Good evening, Siddharth sir.
Good evening.
Ma'am, can we start the session? Jovita, ma'am?
Yes.
Can
Can you hear me now?
yes, ma'am.
Is my slide actually displayed?
No, ma'am.
I'm not able to actually hear you. Yeah, can you hear me now?
Yes, ma'am.
Are you were able to see my slides, right?
No, ma'am.
Okay, fine. Let's just start the session. I think we will just be able to do it later.
Okay, ma'am.
Just give me a minute.
Ma'am, can I start?
Yes.
Okay, ma'am. Good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, I extend a very warm welcome to all our distinguished faculty members and participants. Our focus for tonight is a comprehensive look into the gastrointestinal cancers, exploring the latest updates, clinical practices, and therapeutic advances. Before we dive into our first lecture, it is my privilege to welcome our program director, Dr. Jovita Martin Daniel, professor and consultant medical oncologist, Adyar Cancer Institute, Chennai, Tamil Nadu. Over to you, ma'am.
Hi, everyone. Good evening. So we are in this particular session today. I thank the organizers of IAIO, and I'm just going to give you a gist of, a few words, setting the context as to why today's session is so important. It's because of the rising burden of gastrointestinal cancers in India, and we see that, as a matter of fact, the sites that we are dealing with are colorectal, pancreatic, gastroesophageal, hepatobiliary, and young adults happen to be, a huge proportion of the patients that we're dealing with is not just the older ones. So the key drivers, I believe, could be, urbanization and the kind of lifestyle changes, tobacco and alcohol use, obesity, diabetes, metabolic syndrome, and non-alcoholic fatty liver disease, westernized diet, physical activity, which has really gone down, chronic infections, and also probably a huge proportion of genetic predisposition. And we see a lot of these patients are coming up in late stages, and there's very limited access to screening and early detection. And now we have a huge progress on molecular diagnostics and advanced therapies. Added to that, when we diagnose these cases, we have a huge burden of financial toxicity and unequal access to multidisciplinary care. So there's also a changing landscape that we see with precision oncology and comprehensive molecular profiling in terms of having immunotherapy and targeted therapy and minimally invasive surgeries and modern radiotherapy. So we're going to be having an interaction with multidisciplinary care and supportive oncology. The way forward, I believe, is strengthening preventive strategies and risk modification. So also, expanding the molecular testing and precision medicine in real world. and also making it available, treatment being equitably available for all people. So the point here is that multidisciplinary care is so important, along with equitable access to every patient from the modern advances in cancer therapy. So having set the stage, we would go ahead with the first speaker. Roshni, would you want to introduce?
Yes, ma'am. Um, Let us move to our first scientific session. I would like to invite Dr. Siddharth Lat, consultant medical oncologist from Agram Cancer Center, Ahmedabad. He will be speaking on advance in colorectal cancer management, focusing on molecular profiling, systematic therapies, and immunotherapy. Over to you, sir.
Hello. Hello.
Yes, sir.
Sorry, I could not hear you.
Over to you, sir. You can start
Okay.
your question.
Uh, can you share the slides? I'm not able to share the slides.
Yes, sir. Yes, sir.
So, good evening and a warm welcome to all for this session. Thank you, IAIO, for inviting me to host to present this session. Uh, Today, we'll be talking about advances in colorectal cancer. And since it is a very huge topic, we would be trying to summarize it in the most lucid way. I'll be focusing mainly on three aspects, that is biomarker testing, what is new in biomarker testing, and what is the first line and later line therapy, and then what is new in immunotherapy and targeted therapy. Next slide, please. So basically, we know that uh, our patient can come in any state. If it is the early stage, we usually would not go for an NGS, but universal MMR or MSI testing and diagnosis is suggestible and required at all the stages of the patient, and especially it is important in metastatic disease. If the patient comes in metastatic disease, we must go for NGS testing because we may have markers which are of therapeutic importance. And also, we have the importance of ctDNA coming up uh, in to decide upon the adjuvant therapy in early stages of cancer and to follow up of the recurrence of the tumor. Then we will be discussing the first line and the later line therapy, the immunotherapy and the targeted therapy. Next. So, what influences treatment choices in colorectal carcinoma? There are mainly three factors which decide what treatment should be given, on the basis of which we decide what treatment has to be given. The first is patient characteristics, which are very important. The age of the patient, the performance status, the comorbidities, the prior adjuvant treatment taken. The patient preference is also very important, and it is of utmost important to maintain his quality of life. Then we have to see the tumor characteristics. What is the location of the tumor, that is sidedness of the tumor, what is the tumor burden, what is the resectability of the tumor, if the tumor has been resected, whether an adequate number of lymph nodes were resected, whether there was a perforation or obstruction occurring after surgery, and what is the toxicity profile of the therapy. And then we have to take care of the molecular aspects. In all the colorectal carcinoma patients coming up front, we have to go for MSI and MMR testing. In metastatic setting, we also go for upfront NGS testing and HER2 amplification testing if KRAS and BRAF are absent. Next. So coming to the biomarker testing, what is the rationale for molecular testing? As I already told, next slide, please. So as I already told, uh, The universal testing and diagnosis is for MSI and MMR testing, and this should be part of the initial colorectal carcinoma workup. MSI high or MMR deficiency is prevalent in about 10 to 15% of localized colorectal carcinoma, but it is only in about 4 to 5% of metastatic colorectal carcinoma. We also know that it has got implications for Lynch syndrome evaluation, and so it becomes quite important. In metastatic colorectal carcinoma, as I already told, BRAF V600E mutation, HER2, MSI, MMR deficiency, KRAS G12C, and other markers like NTRK and RET fusions become important. Next slide, please. So, if we see KRAS non-G12C has the highest prevalence in colorectal carcinoma with about 40%. KRAS G12C has just 3%, though it is the only targetable genetic modification we know. PIK3CA mutation is also quite frequent with 18%, but we do not have therapy as yet designated for colorectal carcinoma. Then we have BRAF V600E, which is about 10%. MSI high and MMR deficiency, as I already said, it is around 4 to 5%. NRAS is 4%, and HER2 amplification can be seen in 3.5%. It is to be noted that in RAS and BRAF wild type tumors, HER2 amplification can be in a higher percentage, that is up to 5 to 14% of cases. NTRK fusions are very rare, but they can occur in 30% of MMR deficient or MSI high patients. PIK3CA is common, but we do not have a targetable therapy as yet. Next slide, please. So these are the recommendations. I have already discussed them. For HER2 amplification, we must go for IHC or ISH. And PCR for other mutations must be done if NGS is not possible. Tumor tissue biopsy is to be preferred rather than liquid or blood-based biopsy. Only in cases where tissue biopsy is not possible or it is unsafe or the tissue is not adequate, we should go for a liquid-based biopsy. Next slide, please. So, what is the implication of RAS and BRAF mutations? Why should we go for it? So, RAS mutation is most frequently mutated oncogene. KRAS is mutated in 45% of colon cancers. In colorectal carcinoma, RAS testing is required prior to anti-EGFR therapy, and KRAS patients having KRAS or NRAS mutation should not be treated with anti-EGFR therapy, because in these patients it has been seen that anti-EGFR does not work effectively. What is the importance of BRAF therapy, BRAF V600E? So it is the primary effector of RAS signaling in the MAPK kinase pathway, and mutations occur most frequently in exon 5, 15, and these can be found in 8 to 12% of patients. Mutually exclusive with RAS mutations, histologically and historically, they suggest a very aggressive and poor prognosis subtype. Now we have therapy coming up for BRAF V600D. We will be discussing it later. So the very important question, next slide, please. So the very important question now comes up is liquid biopsy. So liquid biopsy involves multiple components. It could be ctDNA or cell-free DNA based, which is used for screening, MRD therapy monitoring, and recurrence detection. Then we have circulating tumor cells, which help us in learning about metastatic potential and drug resistance profiling. Then there are exosomes, then microscopic RNA and methylated DNA. Methylated DNA is a pan-cancer and colorectal carcinoma specific screening marker. And then there are tumor-educated platelets. So we can have many of these variants, and they can have different roles. Next slide, please. So there are multiple studies which have been done on liquid biopsy to see the usefulness of liquid biopsy in colorectal carcinoma, especially. And the most important which comes to mind is dynamic study. It was done in stage 2 patients and stage 3 patients. These are two different studies. In stage 2 patients, after 5 years of follow-up, it was very clearly seen that ctDNA guided adjuvant chemotherapy helps in reducing overtreatment. That is, patients who have negative ctDNA after surgery need not go for adjuvant therapy, and they will have a non-inferior result outcome. And it has been proven over 5 years follow-up. Then we have uh, stage 3 patients in whom dynamic 3 study was done, and it shows that in stage 3 patients, the absence of ctDNA post surgery does not mean non-inferiority. So we have to be very careful that in stage 3 patients, we do not decide on adjuvant therapy based on ctDNA. It is only in stage 2 patients that we decide upon, and that too also T3 patients, uh, we decide based on ctDNA. Then there is a very large study which is going on by the name of Galaxy in Circulate Japan, and it has multiple parameters being seen, and it is being done in stages 2 to 4 of patients, and it suggests that ctDNA positivity post-op is a higher strong predictor of recurrence if it is done by serial testing. So serial testing of ctDNA done post-operatively is a good predictor of recurrence. Next slide, please. Then we have other studies like Bespoke, uh, in which serial ctDNA monitoring has enabled early detection of recurrence. And then there is Cobra, the Pathfinder study, and hybrid study. Next slide. So next slide, please. This is the latest guideline alert from ESCO 2026 about the uses of circulating tumor DNA in solid tumors and lymphoma. This is something very basic. We know when should ctDNA be done. It should not be substituted for solid tumor. It should not be done substituted for radiological assessment. It should be done only when we are going to decide on therapy based on ctDNA, not just to do it for the sake of doing. Next slide, please. Next. So we have discussed all this. Next. There are, next slide, please. So we have seen the actionable markers, RAS, MSI, BRAF, V600E, HER2, KRAS. So these we have already seen. Next. Coming to the first line and later line therapy. We have already discussed what influences our treatment choices. These are the patient characteristics and mainly the tumor characteristics, the fitness of the patient. So next, please. Next. So coming to the general treatment algorithm for metastatic colorectal carcinoma, previous slide, please. So in MSI high or MMR deficient patients, if they are metastatic, it is very easy. We go for dual therapy, that is Nivo plus EP. It is now preferred because it has a much superior outcome compared to single agent therapy, Pembro or Nivo. Then in BRAF V600E mutant patients, we prefer to go for encorafenib, cetuximab, and chemotherapy backbone, that is Folfox, if it is MSS or MMR proficient. In RAS BRAF positive patients, we have to go for RAS BRAF wild type patients. If it is left sided, we go for chemotherapy plus EGFR inhibitor. If it is right sided, we go for chemotherapy plus bevacizumab. If it is RAS mutant, the role of EGFR inhibitors is not there. We have to go for chemotherapy plus bevaci. In HER2 amplification, if RAS wild type is there, then only consider TRAS2 based anti-HER2 therapy or dual anti-HER2 therapy or TDXT. In NTRK fusion, we can consider larotrectinib or entrectinib. Next. So, next slide. So, first line sequencing. So, in RAS BRAF wild type, left sided, as already discussed, doublet or triplet chemotherapy plus anti-EGFR. In RAS mutant right-sided, chemotherapy plus bevacizumab. In BRAF V600D, we go for encorafenib plus cetuximab plus M-FOLFOX6, modify FOLFOX6. It is based on the breakwater study, which is a very important study, and it has shown very significant outcomes. We are going to see that later. And in MMR deficient MSI high, we go for dual therapy. Next. So we have already discussed this. Next. So the breakwater study has shown that it is active with objective response rate in 60% of patients compared to the standard chemotherapy, and it has shown a median OS of 30.3%. It was for the patients having BRAF mutation, and BRAF mutation patients having BRAF mutation were given encorafenib plus cetuximab plus modified FOLFOX6 as again standard of care. Next. Next. So there are certain therapies coming in the third line, that is trifluridine and tipiracil, and it is based on the Sunlight trial, which has shown a median OS of 10.8 versus 7.4 months. Then we have fruquintinib based on FRESCO-2, which is an oral VEGFR 123 inhibitor, and it has also shown good response in patients having undergone at least 2 lines of therapy. And then we have multi-kinase VEGFR inhibitor regorafenib. Next. There is an interesting study about continuum of care. Means it is seen that survival gains in metastatic colorectal carcinoma are driven by incremental additions of subsequent therapies, not only by the first line of therapy. But recent studies have suggested that treatment holidays do not worsen overall survival with the benefit of fewer side effects and similar quality of life. So basically, if we give some treatment holidays, we can have good finding in certain patients. It has been seen in at least 3 important studies, and it was seen that 5-FU plus bevacizumab versus no treatment led to a median OS of 20.2 versus 21.9 versus 23 months. So no treatment, in fact, had the best outcome. So thinking of a treatment break after the patient is having a long, prolonged treatment phase for months or maybe more than a year can have a better outcome. Next. So we come to the last part of our discussion, that is immunotherapy and targeted therapy. So basically, why MMR deficient response? We know that MSI high patients are associated with a high number of mutations per tumor. Next slide, please. And these tumor mutations produce neoantigens which can be detected by the immune system. And thus we see that there is an excessive or higher activity of immune system in patients having MSI high tumors or MMR deficiency. So basically there are 4 agents which are important: pembrolizumab, nivolumab, dostarlimab. These are all PD-1 inhibitors, and then ipilimumab, which is CTLA-4 inhibitor. CTLA-4 inhibitors help in making a cold tumor convert into a hot tumor. That means immune cold tumor into an immune hot tumor. Therefore, there comes a significance of ipilimumab. Next. The most important, next slide, please. The
Sorry
most
to interrupt,
important,
sir. 2
yeah,
minutes left for the session.
yeah, I'll try to finish up. So the important studies regarding immunotherapy were Keynote 177, which is pembro versus chemotherapy. As we can see, the median OS was 16.5 versus 8.2 with hazard ratio of 0.59. And the other important study was Nivo with EP in Checkmate 8HW. It was against chemotherapy, and we can see that the median PFS was not attained, and with chemotherapy, it was 6.2 months. Next slide, please. So we see that OS with the Keynote 177 was significantly higher, that is more than 50 months, more than 4 years against 36 months with chemotherapy. Next. And chemotherapy in first line gave us some indications that it is an effective therapy, and It is associated with good quality of life, as was seen in the study. Next. So, though there is no head-to-head comparison, if we try to take out some inference, we can see that chemotherapy in Keynote 177 uh, led to a median PFS of about 8 months. Pembrolizumab led to a median PFS of about 17 months, while Nivo EP led to 854 months of PFS. So it is now the first line of therapy in metastatic colorectal carcinoma, which are MMR deficient, MSI high, rather than chemotherapy. Next. There was also one other study, that is Checkmate 142, which was a phase 2 study, and it was done with nivolumab plus EP in MSI high MMR deficient patients. And it also showed that 5-year PFS remained high with median PFS not reached once Nivo with EP was used. We can see that overall response rate with Nivo plus EP is around 70%, a complete response rate of 30%, partial response rate of 40%. And as against single agent, the difference in overall response rate is 13%, which is quite significant. Next slide, please. Then we have other studies where single agent was used and it was not effective. It was used in MMR proficient MSA microsatellite stable patients. An effort was made with Pembro plus lenvatinib, but it was negative. Then we tried regorafenib plus Nivo EP, and it was also negative. Then an effort was made with a newer ongoing studies are there with a newer CTLA4 inhibitor, that is botensilimab, along with PD-1 inhibitor balstilimab, and it has shown overall response rate of about 22% with improvement in survival also. So this is an ongoing therapy and it could come out to be positive in future. Next. Then we have targeted therapies for anti-EGFR, cetuximab, panitumumab, side. Next, BRAF in Beacon colorectal carcinoma study. It was BRAF targeted therapy, and we have seen that encorafenib plus binimab plus cetuximab showed a response rate of 27%, while the doublet showed a response rate of 20%. However, there was no change in PFS. So doublet therapy is being preferred. Next, then we have, next slide, please. HER2 targeted therapy. There are important studies in it. That is Heracles with Tras2 plus Lepatinib, then Mountaineer study, Mountaineer 1, Mountaineer 2, Mountaineer 3. These are important studies, and Tucatinib plus trastuzumab has been used in RAS wild type HER2 amplified colorectal carcinoma. It was FDA approved in 2023, and median duration of response was 12.4 months, well, median OS of 23.9, and overall response rate of about 38 to 39% was seen. Though toxicity concerns are there, but it has found to improve survival. And then we have a very well-known study, Destiny colorectal carcinoma CRC02 study, trastuzumab deruxtecan. It has shown a very good response rate of 45.3, and it is being used now. Next, interstitial fibrosis has to be monitored. And then we have regime against KRAS G12C, adagrasib plus cetuximab with an overall response rate of 34 to 46% and median PFS of 6.9 months. We have to ensure that we give dual agents. Single agent therapy is not effective. Then there are tumor agnostic markers, that is NTRK fusion, lerotrectinib or entrectinib can be used. RET fusions, selpercatinib can be used. Next. So coming to the last slide, we have to test everyone for MSI, MMR. Biomarkers change therapy. So biomarkers have to be checked. Immunotherapy should be used as and when required. And we must sequence the whole continuum. Means we must go till the third or fourth line of therapy because it can improve the survival of the patient. Uh, I would close my talk here. I could not cover rectal carcinoma in detail because it was a very long topic. And I thank everyone for being having patient listening. Thank you.
Thank you,
Over
sir.
to you, madam.
Yes, sir. Uh, Next, we shift in hepatobiliary and pancreatic cancers practical updates. It is my pleasure to invite Dr. K.C. Gautam Reddy, Clinical Director and Senior Consultant, Medical and Radiation Oncologist from Dhanja Cancer Center, Hyderabad. Welcome, sir.
Welcome. I am Dr. Gautam. Um, the topic that has been presented is actually very long. So I'm covering three different cancers and three most important topics of each cancer. So I'll not be going into much details of evidence. Rather, I will be giving you a glimpse of what is the rationale, both biological rationale and evidence rationale of selecting the treatment and choosing to do what we do generally. Let me start with let me start with hepatocellular carcinoma. Can you slides? Anyone, can you present my slides?
Yes, sir. 1 minute.
Yeah.
Sir, is it visible?
Yes, it is visible.
Okay, sir.
The topic is very extensive. As shown in the picture, it covers liver, the biliary tracts, and the pancreas. Okay. So can you change it?
Sir, I have done. Next slide.
Yes, thank you. We'll start with hepatocellular carcinoma. The topic that has been specifically mentioned to me is treatment sequencing. It means that what are the different type of treatments available and how we select one treatment after other treatment. So being a medical oncologist, I'm expected to be confined to systemic treatments, but just for the sake of review and completion of the topics, I have listed all the treatments that are available for hepatocellular carcinoma in a single slide. So the next slide will let us know what are all the treatments that are actually or practically available for hepatocellular carcinoma. Change the slide, please. Yeah. So what are the treatment options? Liver transplantation, hepatic resection, tumor ablation, transarterial chemoablation, transarterial radioembolization, transarterial chemoembolization, and transarterial radioembolization. Next slide, please. External beam radiotherapy in the form of stereotactic body radiotherapy, hypofractionated radiotherapy, immunotherapy. The present uses like etijolizumab, the most commonly and for which most of the evidence is there. Durvalumab, nivolumab, pembrolizumab, tislelizumab, tremelimumab, and ipilimumab. Tyrosine kinase inhibitors, as we all know, sorafenib, lenvatinib, regorafenib, cabozantinib, rivosiranib, etc. There are also certain anti-VEGF inhibitors like bevacizumab and ramucirumab. Then we should never
Gautam, sir.
I think Sapna, he should be joining again. There was some network issue.
Okay, ma'am. Okay.
Sorry for the disturbance. There had been a small disturbance on my side. Very sorry. Am I audible?
Yes, sir.
Yeah. So now that we understood what are all the different kind of treatments that are available in hepatocellular carcinoma, we have to decide how can we arrange all these treatments so that we can help the patient as much as possible. Things have had been made easy by the grouping that has been previously provided by BCLC. Let's go to the next slide. The next slide actually decides upon what are the factors which help us to determine the sequencing. So the first most important factor is the tumor burden and anatomical stage. The next factor is liver function and hepatic reserve. The third factor is portal hypertension and vascular status. Then comes the performance status, friability, and transplant eligibility. All these things are important because they let us know whether a local therapy can be added, a systemic therapy can be added, whether two systemic therapies can be added at a time, or immunotherapy should be added, or two immunotherapies can be aggressively added. All these things are very important. Next slide, please. So these factors, when arranged in proper way, which we usually call BCLC staging, we define it as BCLC very early, intermediate, advanced, and end stage. Thing is, still BCLC 0, A, B, we do have various kind of local therapy options which can be used to increase the survival rate of these patients. From the advanced stage, we have systemic therapy. One thing that we have to always remember is, even in metastatic disease, which we call BCLCC, we should never hesitate to use local therapies wherever possible in some or other minute way. It would definitely give you some survival benefit. Now, let us see how systemic therapies can be played upon, on why these systemic therapies will actually work and why they don't work, and how to select between different kinds of systemic therapy among the available ones. Next slide, please. So I have divided this systemic therapy into first line and second line, through which most of our systemic therapy questions and questions and decisions are depend upon. I have not specifically included any third line therapies as such, but whatever are not used before in first line or second line can be applied to the third line. Next slide, please. Yeah. What are the first line treatment option? The gold standard one, Etijobev, it has shown both survival benefit and PFS benefit. Stride trial, which tremelimumab with durvalumab, nivolumab with ipilimumab, camrelizumab, and rivosrenabine. All these are first line treatment options. Among these one, the gold standard one is Etijo with bevacizumab, because it has two distinct biological advantages, which I will be mentioning further. Okay, next one. So why Atijobev is something which is used rigorously, and why it is showing such a good response? One thing is that hepatocellular carcinoma is very vascular. Biologically, it is very vascular. If it means that it is biologically very vascular, it means that the tumor microenvironment releases lot of angiogenesis factors, and these angiogenesis factors may be retained, and the tumor may also utilize these angiogenesis factors and the receptors and the pathway associated with to grow. So we are assuming the cancer that has arisen from primary liver will retain the vasculogenic pathway that has been seen previously. That's one reason. Second reason is that hepatocellular carcinoma itself is a immunosuppressive. It has an immunosuppressive environment. Why it has immunosuppressive environment? The logical reason is, most of the whatever we take in, whatever we consume through suppose we take lot of food, we took lot of intelligence, ultimately reach liver in some or other way. If liver starts reacting to those substances aggressively, it would be a mess and we would cause lot of problems. That's the reason the human body has constructed liver in such a way that it is inherently immunosuppressive. And when the tumor also through the pathways that are naturally present in the liver will be immunosuppressive. That's the reason immunotherapy drugs or the pathway drugs which affect the immunotherapy will be more effective in liver cancer. This is also relevant in dealing with immunotherapy toxicities, because when we are dealing with immunotherapy toxicities, the most common toxicities that we usually see include hepatitis. That is because this liver is inherently immunosuppressive. The moment you add some more immunotherapy drugs, that inherent immunosuppressive prosthesis is inhibited, and we see a lot of hepatitis and those kind of adverse effects in these cancers. Apart from this one, there is not only single immunotherapy pathway that is existing in these liver cells, hepatocellular cells, and then hepatocellular carcinoma. There are multiple immunosuppressive pathways. That's the reason the if you add some more immunotherapies and if you inhibit immunosuppression a little more, the cancer also can be controlled in a better way. So that's the reason why two type of agents or double agents, one thing a vascular, other thing is a etijo, will together will give you the best results in case of hepatocellular carcinoma. Next slide, please. So there are other, so I have mentioned two combination chemotherapies, the best options. The other first line options, because we are in a country where financial toxicity also plays an important role in dealing with cancers. We have durvalumab monotherapy, tislelizumab monotherapy, lenvatinib, sorafenib, and pembrolizumab. One thing I just wanted to mention is tislelizumab and pembrolizumab, because right now these agents are, I don't say they are completely available, but these agents are within a reach, along with nivolumab, are within a reach to common public, and we can play around them. That's the reason I have included few monotherapy options. Next slide, please. So how do you select a first line treatment? What factors you decide to select one treatment over another treatment? First thing, patient is fit. Patient has no vascular anomalies. There is no major bleeding risk. We go for the best option, etijo with bevacizumab. Then, in case we have certain risk factors to use vascular agents or anti-vasculogenic agents, we go for the next best option, tremelimumab with durvalumab or nivolumab with ipilimumab. Then we need high probability of tumor shrinkage so that we can add upon some local therapy. We can go for etijobev and nivo ipilimumab are also being used. But one thing we need to be careful is we add double type of agents, one PDL1 blocker, one CTLA blocker, and all those things. We need to be double careful regarding the toxicities that are going to come, because we are affecting two immunosuppressive pathways in hepatocellular carcinoma. Not suitable for VEGF. Again, we have the STRIDE trial where we use tremelimumab plus durvalumab or nivolumab or ipilimumab, and we need lower treatment related toxicities than your immunotherapy. We think that patient may not tolerate hepatitis and all those things. We can use durvalumab monotherapy or tislelizumab monotherapy. Next slide, please. In case we the patient only in case of contraindication to any other immunotherapy, we can use TKIs like sorafenib, lenvatinib, severe autoimmune disease, solid organ transplant, all these things where immunotherapy is actually contraindicated, we can use it. Uncontrolled hypertension, significant proteinuria, again, where the bevacizumab is contraindicated, we can use single agents, durvalumab, nivolumab, and all those things. Major wounds, bevacizumab is contraindicated, only immunotherapy drugs will be used. Patient wants oral treatment, has difficult to travel for thing, it is lenvatinib. And again, we need to remember that subcutaneous drugs have been come even in immunotherapy, which will reduce the traveling burden to the patient and hospitalization burden to the patient. And never forget, there is always a treatment option of best supportive care for these kind of patients. And as I told, all the things should be considered to play around the sequencing. Now, once the first line treatment options have been selected, have been introduced to the patient, what to do next and how to proceed next. Next slide, please. So we have given the first line treatment options. We have seen the survival results. Now, when will you change the treatment? How will you decide on what treatment should be given next? So what are the principles? First, we distinguish between disease progression and treatment intolerance. Many a times, all these agents will cause a lot of toxicities. So you need to decide upon whether it is progression or intolerance. Use predictive biomarkers and the pattern. And again, don't forget, use local treatments for limited oligoprogressive diseases wherever that is possible. Watch for the toxicities, feasibility of the patients, especially in liver cancers, because the toxicities, many a times, even in my experience, toxicities play a major role in determining or tolerating the treatment. Next slide, please. The other thing is liver function, performance status. What is the first line treatment that was given? Next slide. So what are the second line treatments? So it depends more upon the performance status, and mainly what would be the first line. If the first line treatment is etijobev, the second line treatment can be gone with cabozantinib, lenvatinib, and sorafenib. So we have used both the agents. Always remember, if we targeted one pathway previously, always remember to change the pathway and target it next. And then there are different. Sorafenib was used previously, use regorafenib and cabozantinib. Especially in the previous drug, distinguish treatment intolerance to treatment progression. Lenvatinib was used, use cabozantinib or any immunotherapy regimen if possible. If single agent immunotherapy is used, try to use or combine multiple agents immunotherapy. Okay, next. Remember, in case of post-liver transplant recurrence, the patient will be already on a lot of immunosuppressant drugs. The only options that are available is TKS, tyrosine kinase inhibitors. Next slide, please. So what are the emerging options? Not yet standardized, but something that is coming to me. FGFR inhibitors, MET pathway inhibitors, WNT beta catenin inhibitors, and rare infusion directed precision therapy like RET fusions and NTRK fusions. All these things should be remembered because the science is rapidly evolving and the evidence is rapidly evolving. We don't know, within next year we may have another drug which can act better than the drugs that are present previously. I think I'm clear. To just round up and let you know, revise the things. Hepatocellular carcinoma, the all treatment options, TACE, STAIR, liver transplant, liver resections, immunotherapy, tyrosine kinase inhibitors, bevacizumab. Once we know all the treatment options, first assess the patient, particularly whether he's suitable for treatment or not. Many people have a lot of treatment intolerance. Select the right treatment. If the right treatment is selected, the life would be more peaceful, more easy. Select the right treatment, prolong the lifespan. When progressed, identify whether it is oligoprogression and what kind of progression is. Always remember to add local therapy as early as possible. Continue the systemic therapy by changing the line of treatment. Now, with this, I'm just summarizing the hepatocellular carcinoma. The topic is sequencing of hepatocellular carcinoma. The first best choice is etijobev. Check for autoimmune diseases or immuno-related complications. If no autoimmune or immuno-related complications are there, if the first best choice can't be used, try to use double immunotherapy agents or single agent durvalumab or something. If some kind of immune related complications are present, go to TK. The best proven drug right now is lenvatinib. Watch for toxicity, especially the hand foot syndrome and all those things. Give mandatory prophylaxis. Watch the patient. Go ahead. Based upon what drug was previously used, go to the next line of drug. Most important, cabazantinib will act wonderfully even in hepatocellular carcinoma. Once cabazantinib is also used, remember best supportive care is also present, which should be continued. The other treatment lines are newer things, FGFR, MET, and all those things. With this, I'm concluding hepatocellular carcinoma. We'll go for the next slide. Next would be cholangiocarcinoma. What are the actionable mutations and treatment? Cholangiocarcinoma, since age, has been termed to be very bad cancer. Bad cancer because we don't have much treatment options till now. But recently, we found out that majority of cholangiocarcinomas have certain kind of actionable mutations, and immunotherapy has also entered into cholangiocarcinoma space. Problem with cholangiocarcinoma, one important problem with cholangiocarcinoma is we can't get enough tumor sample. So we have to be very careful during the earliest intervention that we get enough tissue sample to do all the tests that are important. Though it may be sideline or it is a basic science, getting enough tissue samples and sampling it to understand the mutational status is important. ctDNA also works, but the problem with ctDNA, especially in cholangiocarcinoma, is we may find lot of false negative results. Next slide, please. So molecular profiling is important. Go for DNA-based NGS, also RNA-based fusion testing, supplemented by lot of ISC tests like HER2, MMR, ISC, and MSA testing. Targeted therapy, right now, most of the targeted therapy are in second line, but second line after GEMS is immunotherapy, but do not hesitate to change the sequence after discussing with the patient in case of there are major contraindications. Cholangiocarcinoma patients, by the time they present to you, are already weak. They may or may not tolerate GEM and CIS and immunotherapy. So be careful. You can push upon certain treatments more aggressively if the situation demands. Next slide, please. So the most happening thing in cholangiocarcinoma profile is FGFR mutations, for which we have multiple drugs that are present. Right. Next slide, please. Next slide, please. So again, what is the testing panel? DNA-based NGS, RNA fusion pattern, HER2 testing, mismatch repair, tumor mutational burden, germline, which are usually common. Next. So there are again two things. Why I had particularly mentioned about two different types of cholangiocarcinoma, and common thing is uh, whenever we order a test or when we think that the test itself is costly, we have to be very careful to at least ask for the test that we actually need. Intrahepatic are more towards FGFR, IDH1, BRAF. Extrahepatic are more towards HER2 amplification, KRAS, and TP53. This biological difference should be kept in mind to understand the disease and understand the necessary medications that has to be given. Next one.
Sorry to interrupt, sir.
Yeah.
2 minutes left for the session.
Okay. So I think 2 minutes is not sufficient. I probably will be skipping the pancreatic part. So again, we'll confine to the we'll confine to the cholangiocarcinoma part only. In case of FGFR mutation, the most problem is pemigatinib and futigatinib. IDH1 is the ivosidenib. And just go back. Those things are more important than this one. Go to the back slide. And head to expression, we have janatumab and trastuzumab deruxtecan. BRAF, we have dabrafenib and trafatinib. With this one, I'll conclude. I am missing an important part called pancreatic cancer, which was very interesting, especially due to recent ASCO event. Daraxonib has recently entered. Other few things that have recently come up in pancreatic is there is a lot of neoantigen tumor vaccines, and CAR T cell therapy is also, they are conducting CAR T cell therapy trials also in pancreatic cancer, because it shares, because the gastric cancer trial that happened in China, which proved some result, the same, the claudin for which the CAR T cell therapy is being done, is also some subsets of pancreatic cancers also have the same mechanisms, and they were trying in pancreatic cancer also. There is not much days left where we will see a lot of CAR T cell therapies in solid tumors also. Thank you very much.
Thank you, sir. Thank you, sir. We now will look into a closely at upper GI cancers, esophagus and stomach. I invite Dr. Akila KB, consultant medical oncologist from VGM Healthcare Center, Coimbatore, to share the insights. Over to you, ma'am.
Good evening, all of y'all. Are you able to hear me?
Yes, ma'am.
Yeah, but I mean, my slides are not in the slideshow. I'm not able to see the slides.
1 minute, ma'am.
Yeah.
Start. Ma'am, is it visible?
Yeah, right. Thank you.
Thank you, ma'am.
Well, yeah. Next slide. Well, all of us know like gastric cancer is the 7th most common malignancy, and it is the 6th leading cause of cancer-related death. And most of it is adenocarcinoma, or almost 75%. And when we see the presentation, it is like almost 50% of them present to us with a loco-regional disease. And distant mets is there in almost 25% of patients when they come to us. And the overall survival remains extremely poor, and it is less than 20% because of the late stage of presentation. Next slide. Next slide. Yeah, the same with the esophagus. Again, it is a late presentation. It is the 5th most common and the 5th leading cause of malignant deaths in India. Next slide. Yeah, and what are the biomarkers we need to test in esophageal and OG junction and gastric malignancies? Basically, since we have targeted therapies and IOs now and newer molecules, like we have to know whether the patient is having a hereditary syndrome. So the biomarkers, what we are going to test will be HER2, PD-L1, Claudin, and MMR and MSI. All these can be tested by IHC. Next slide. Coming to HER2, its overexpression occurs in almost 8 to 20% of malignancies in the esophagus, OG junction, and proximal. If we are doing HER2 in the surgical specimen, the specimen should have more than 10% of tumor cells showing strong HER2 positivity. And if it is in an endoscopic biopsy specimen, at least more than 5% of tumor cells should be HER2 3+. And there is almost 75% of heterogeneity within the tumor. So definitely at least 6 to 8 biopsy fragments are necessary before we report HER2. Next slide. Yeah, and if we see, compare the primary tumor and the metastatic tumor, almost 93% concordance, both by IHC and FISH. And sometimes this, like in around 6% of patients in a metastatic disease, HER2 negative have become HER2 positive, especially in liver mets patients. Next slide. Next slide. Next slide. Yeah, coming to PD-L1 expression, we all know it is an inhibitory checkpoint receptor. It is expressed on cytotoxic T cells and other immune cells. It binds to its ligands and maintains the immune cell tolerance during immune regulation. And it also binds and inhibits the T cell receptor signal. So some tumor cells express higher level of PD-L1 expression, and this leads to immune evasion mechanism, which includes the inactivation of cytotoxic T cells. So this is an important checkpoint inhibitor, which is going to control the tumor. Next slide. Yeah, and coming to the expression, at least 35% of patients has a CPS score of PD-L1 in upper GI malignancies. Around 60% has a score of more than 5, and almost 78% will have a score of more than 1%. Again, here there is a discordance between biopsy and surgically resected specimen requiring at least 6 samples to report on the PDL1 status. Next slide. Yeah, if we are using Nivo, it is going to be a TPS score, and if we are going to use Pembro, it is going to be of CPS score. Next slide. Yeah, this is again all we know. What I think all of us are familiar with CPS and TPS now, and tumor area positivity is a new one, where the percentage of tumor positivity versus the tumor positive and immune cells versus the tumor area. So this is a new one. Next slide. Again, there is a concordance rate of almost 61% between the primary and the metastatic tumor. Next slide. And now this is a new one. It is like claudin protein. It is a key component of the tight junction complex. This protein will regulate the cell polarity. So what happens if this polarity is lost? The tumor is going to metastasize. This is predominantly found in gastric mucosa and remains present in gastric tissues after they become malignant. Next slide. Next. 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 Yeah, just the previous slide. So I mean here again, at least 25% of discordance is going to be there between the primary and metastatic sites. Yeah, next slide. So why are all these biomarkers important? Now we have the targets, we have IOs. So definitely how are these going to be useful in the management? Next slide. Yeah, if we come to management of resectable gastric malignancies, if we see according to the stage, it's stage 1A and 1B alone does not need any neoadjuvant or chemotherapy or radiotherapy. But if we see stage 2 to stage 3 and further stages, there is a definite role for chemotherapy. And peri-op chemo is being used for stage 2, stage 3. Invariably, these stages where they are resectable. So which means any more than T2 or any N1 patient. And if there is a role for chemoradiation, if less than D2 dissection is done. And if D2 dissection is done, it's only post-op chemotherapy. Next slide. Next, yeah. The recurrence, of course, it is like the proportion of patients who recur is almost 61% after surgery. And 43% of them recur within 2 years of surgery. Next slide. Yeah, of course, like MAGIC trial was an initial trial where peri-op chemotherapy showed an importance of it in managing the GI malignancies, where there was an increase in the overall survival. With peri-op chemo alone, the survival had increased from 23% to 36%. Next slide. Of course, FLOT and modified FLOT had become the standard of care now. Next slide. So in want of time, I think I'll just skip through most of it. The Top Gear and EZOPEC, these are the trials which showed when tested for neoadjuvant chemoradiation, there was no increase in the overall survival and progression-free survival. So next slide. Yeah, now see, by now we know now that peri-op chemo is going to be useful for patients. But is peri-op IO going to be useful for patients? Yes, of course. How and why? So this PDL1 expression is there, but it is associated with a negative prognostic factor. It is expressed in almost 40 to 60% of OG junction and gastric adenocarcinomas. What does this do? This primes the systemic immunity by exposing the tumor antigens to the T cells. It clears the minimal residual disease via the activated T cells, and it builds the immune memory. So definitely, immunotherapy has an important role in decreasing, in the prognosis of malignancy. Next slide. So what are the clinical trials which used IOs? See, all of us know that by now the main IOs are going to be Pembro, Durva, Ati, and Nivo. Of course, we are waiting for the results of Periop atezolizumab, but we have results of neoadjuvant Pembro, Nivo, and Durva, of which Pembro and Nivo was a negative trial, and Durva alone was a positive trial. Let's look into the trial with Durva. Next slide. Yeah, next slide. So it is this Matterhorn trial, which was presented in ASCO. What does this trial do? It was a global trial. It was a phase 3 randomized double-blinded placebo control. What did these patients do? In resectable stage 2 and stage 3 malignancies, which had a histopathology and clinical diagnosis of more than T2 or any N1, but there were no mets in these patients. They were eligible for radical surgery. And here the PDL expression status was checked for these patients. These patients had been randomized into 1:1. Almost 950 patients were there in the study. 1:1 with a dose of durvalumab versus placebo with FLOT. Durvalumab was given once in 4 weeks at a dose of 1,500 milligram. It was after 2 injections, like surgery was done, followed by 10 more cycles of durvalumab with maintenance. Here again, like FLOT was given in the common standard dose, placebo was the control group. Next slide. Yeah, and what had happened? See, patients who completed surgery was almost equal in both groups. Completed the regimen and attempted surgery, and completed the durvalumab or placebo was also equal. So, which here by this slide, we mean to say that there was no added toxicity with durvalumab. That is why patients could complete the treatment. Next slide. What had happened to the event-free survival? At the end of 2 years, if we see, the event-free survival had increased from almost to 10%, from 58 to almost 68%. And durvalumab plus FLOT again, if we see at the median age of duration of follow-up, both patients had been following up for almost 31 months. Next slide. Same overall survival, if we see, it was not reached in the durvalumab arm, but in the placebo arm, it was almost 39.8%. So here, if we see at the end of 3 years, like 68% of patients with durvalumab were surviving, whereas only 62 in the placebo arm. Next slide. Yeah, what had happened? All the subgroup, all the participants, irrespective of the PD-L1 status, showed a response to durvalumab. So whatever be the tumor baseline characteristic, every patient responded to durvalumab. Next slide. Again, if you see the PD-L1 status, there was not much of a difference, except that we have to know that PD-L1 score more than 1 is better. And if we see the overall survival according to the PD-L1 status, it was like around with a hazard ratio of almost 0.79 in both arms. Next slide. And what happened to the PCR? It had increased from 7% to 19% by adding durvalumab to FLOT. So with an odds ratio of almost 3.08, an increase in 12% of PCR had occurred. Next slide. And of course, the event-free survival, if we see, had increased as per the PCR. For patients who had received the PCR, the event-free survival was more. And this is again the event-free survival according to the PCR scoring. Definitely durvalumab was preferred and it showed a better PCR response. And as per the response, the event-free survival had increased. Next slide. Next slide. And of course, all of us know the toxicity is going to be mainly because of the chemotherapy. The addition of durvalumab did not have a major decrease in the treatment in patients. The main toxicity was diarrhea and nausea, which was well managed symptomatically. Next slide. Yeah, so the key takeaways. Now with immunotherapy, improved, only durvalumab is off now, the immunotherapy, which can be given along with FLOT regimen in the peri-op setting. And there was no safety concern when we used durvalumab. Next slide. So I think here we know now, durvalumab is going to be important. Now we are also, so IO has a real role in peri-op chemotherapy. Now, what has happened in the metastatic setting? So we are testing HER2 also and IO. So now let's see how we are going to integrate this IO and this targeted therapy. Next slide. We have this Keynote 811 trial. Here, it is again a phase 3 global trial where the patients had either OG junction or, gastric malignancies. They were locally advanced, unresectable, or metastatic, who were HER2 3+ patients. And of course, a CPS score was done for these patients. And the patients were randomized to receive pembro along with trastuzumab versus with the chemo, which is going to be capox. And in Japan, the chemo which was used was S1 instead of oxali, and instead of capecitabine, and trastuzumab with placebo with the chemotherapy was the backbone of this trial. They were randomized as 1:1. Pembro was continued for 2 years or until the disease progressed or the patients withdrew the consent or if there was a toxicity. The primary endpoint was overall survival and the progression-free survival. Next slide. Yeah, the patients with the baseline characteristics were matched in both the arms in the placebo versus the pembro trastuzumab arm. 81% were male, 68 had gastric tumors, out of which 50% had intestinal type, and all 80% had HER2 3+ tumors. Next slide. 86% had capox regimen along with pembro trastuzumab, whereas 15%, almost 15% had cis-5FU as the chemo backbone. Next slide. What had happened at the end analysis or after 50 months of follow-up in this trial? Next slide. Yeah, coming to the overall survival, if we see, the patients had a definite improvement in the overall survival with a hazard ratio of 0.80. Had the patients received pembro, the survival was almost 20 months, and in the placebo arm, it was only around 16.8 months. And if we see at the end of 3 years, the patients 28% of patients who had received pembro were alive, but only 23% of patients who had received the placebo arm were alive. This immunotherapy with trastuzumab combination had a consistent improvement along over the years in the overall survival. Next slide.
Sorry to interrupt. 2 minutes left for this session.
Yeah. Here again, irrespective of all the groups showed an improvement in the survival with pembro and trastu. Next slide. Next, the PFS had increased from 8.1 to 10 months. Next slide. Yeah, the response rate was almost 48 in the placebo arm and 55 in the pembrolizumab arm. Next slide. And the duration of response had increased from 9.5 to 11.5 months in the pembro arm. So irrespective of the PDL1, and the most thing is important is even if the score is just more than 1, definitely pembrolizumab had a score over the placebo arm. Next slide. This is again irrespective of, pre-specified. If we see PDL1 score more than 1, there was a survival improvement of almost 5 months. Overall survival itself had improved. And if the score is less than, it is just a 2-month benefit. Next slide. Yeah, all of us know the toxicities are here going to be immune-related toxicities, which were well manageable in this study. Next slide. Yeah, I think here we end. And this is another newer molecule for which in patients who had Claudin positivity, of course, we have two trials, Spotlight and the Glow, again, where there was an overall survival benefit seen with these newer molecules along with the backbone of chemo. Yeah, with this, I think I end my presentation. Of course, newer molecules like tislelizumab, toripalimab, all are being used now and all are showing improvement in the PFS and OS. And I thank you all for patient listening and giving me this opportunity.
Thank you, ma'am. We now move on to one of the most anticipated segments of our evening, the interactive tumor board and case-based discussion to evaluate challenging real-world GI oncology cases. I am delighted to welcome our moderator, Dr. Jovita Martin Daniel, professor and consultant medical oncologist, Adyar Cancer Institute, Chennai, Tamil Nadu, and our distinguished panel of experts, Dr. Shaina Goyal, Senior Consultant Medical Oncologist from Max Super Speciality Hospital, Delhi, Dr. Surjana Joga, Consultant Medical Oncologist from Kamini Hospital, Hyderabad, Dr. Karthik, Consultant Medical Oncologist from VS Hospital, Chennai. Over to our moderator.
Good evening. Actually, I really appreciate Dr. Rudra for having the IAIO and creating this platform for sharing of knowledge and, the latest updates, which is really going to be informative for many people. And I thank the speakers, Dr. Siddharth Lat, Dr. Gautam Reddy, and Dr. Akila for beautiful presentations and a special acknowledgement to Dr. Akila, my senior and my very good friend and sister, and Dr. Gautam for a very, very, lovely presentation. I'm just it was very beneficial actually listening to that talk. So let's go to the case presentations. I'll quickly take you through 5 quick presentations. So I think we have 3 people on board with us for the panel discussion. So we are aware of the fact that there's a huge rise in young onset GI cancers, right? So about plus 2.5% increase in colorectal cancer incidence every year. We have about 10 to 15% increase in the gastric and pancreatic cancer. There is a delayed diagnosis and there's so much that needs to happen about, the fertility, the carrier, planning, especially with young families and cascade testings if we find out if there's any kind of mutation that is detected. And I'll quickly take you through some of these, cases. The relative burden, if you look at the 5 GI cancers, for colorectal, it is 9.6%, gastric 4.9%, hepatocellular is 4.3%, pancreatic is 2.6%, and esophageal is 2.6%. Overall, around about 25% of cancer cases all across the world, it's because of the GI cancers. So we are aware of the fact that gastric cancer is more H. pylori driven, and it could have CDH1 mutations, and it's more because of the salted diets that we have and smoking. Pancreatic cancer is more because of the SMAD4 mutations, TP53, KRAS, and CDK2N2A, which actually are the mutations which drives the pancreatic intraepithelial neoplasia into carcinoma. And we also have the drivers BRCA2 and PALB2. Hepatocellular carcinoma more because of the chronic HPV infections or non-alcoholic liver disease, cirrhosis. So colorectal, again, we have, all the mutations like KRAS and TP53. Esophageal cancers because of the Barrett's metaplasia and dysplasia leading to adenocarcinoma, or it could be squamous cell carcinoma. Now, let's go into the 5 quick cases. They are hypothetical cases, which I have actually put across. Now, there is a 37-year-old man who had 12 months progressive dysphagia for solids, and then if proceeding to liquids, he had a 10 kg loss of weight with him, and the patient has been on antacids and empirical proton pump inhibitors for 6 months. The long-standing history of gastroesophageal reflux disease for over 10 years. He smokes 15 pack years smoking, and no prior Barrett's esophagus, with a family history of father having squamous cell carcinoma of the larynx. Hemoglobin 10.8, albumin about 3, CEA is 12, and he had difficulty to swallowing about grade 3. Now, upper GI showed a friable mass in the distal esophagus extending to the gastroesophageal junction, and it was non-obstructing invasive adenocarcinoma. Ultrasound finding, it was actually involving the periesophageal and celiac nodes, which is N2. In PET also, it demonstrated the same. Celiac lymph nodes were involved. However, it was oligometastatic in the sense that there was a liver lesion, a single organ, and a single lesion. Histology, moderately differentiated adenocarcinoma, rising from the Barrett's esophagus, and there was irregular glands. That I'm not getting the description. So IHC, there was HER2 positivity and proficient MMR. PDL1 was CPS 8, and Claudin was negative. Now let's go into the in general, we see that squamous cell carcinoma is 83% and adenocarcinoma is 16%, but the reverse is true, especially when it comes to well-developed countries like Western Europe or Northern America. And we have, very less people do this Barrett's esophagus surveillance or endoscopic screening with the high-risk groups. So that's one of the issues that we are facing. So chemo prevention also is not really much established. Now let's go into the discussion points. Dr. Sheena Goel. So this is basically ablatable, resectable kind of a lesion that is there in the liver mets, which is actually a blurred line between palliative to curative. So what's your take on this particular stage 4, and how exactly would you want to position your treatment here?
Hello, ma'am. Good evening, Dr. Shaina here. So I think this is a very common scenario that we see, though a younger age patient, but the presentation of dysphagia with a very significant loss of weight and history of smoking, finding to have this sort of a disease. So interestingly, it's an adenocarcinoma, which is HER2 positive by 3+ by IHC. So as was presented by Dr. Akila also, definitely there is I would want to use anti-HER2 therapy. and CPS score is also 8. It is just intermediate. However, we can consider him for addition of because it's more than one, for addition of pembrolizumab along with TRAS2 and chemo. The question on it being an oligometastatic disease and doing resectable lesion of the liver, I think that is not very well defined in gastric cancers. We have more encouraging data in colon with these sort of solitary meds. So knowing the gastric cancer biology, I would want to start this patient on systemic therapy and consider a response assessment after, let's say, 4 cycles. And I would like to see the disease biology by continuing the systemic therapy and later consider for a local treatment if continues to do better.
Excellent, actually. On dot, you nailed it on the dot. So if it is, now we see that the CPS score is 8. It's kind of intermediate. It's not more than 10. So we have data more than 10. So what's your take on using pembrolizumab, I mean, any immunotherapy? Dr. Srujana Joga?
Yes, ma'am. Very good evening. So, truly said, the data is more for the larger benefit of immunotherapy is seen in patients with CPS score more than 10. So, with the 8 score, the benefit of immunotherapy is still skeptical. So, if the finance is an issue, I would like to avoid immunotherapy and just add chemo as well as targeted therapy to this patient.
Excellent, yeah. But, having said that, more than 5, I think we have data for nivolumab. However, if, as you said very rightly, if finance is not an issue, then we may add both. I think they will be benefiting. And how about radiation in this case? Dr. Karthik, do you have anything to add here?
Yes, ma'am. Good evening. So thank you for the opportunity. So here we have a very young patient. So I would go ahead with an aggressive treatment. As ma'am already said, we'll have a response assessment after 3 to 4 cycles. And if the patient does really well and if the response is really good, I would consider changing it to a curative intent based on the response of the liver disease. If it is completely cured, then I will go ahead with a consultation of radiation. Otherwise, continue systemic therapy.
So what will be your dosing?
It is the intent here is again, if suppose we consider in the future, the intent here will be curative. So dosing will definitely be 45 to 50 gray, the curative dose.
All right.
Yeah.
Okay. So I just want to have a thought on, the new onset hoarseness that is there present for the patient, recurrent laryngeal lymph node, laryngeal nerve involvement. So how does this affect the surgical candidacy if the local therapy is later considered? Dr. Sheena, would you want to take that question?
Yeah, so I feel the recurrent laryngeal nerve involvement, I'm not sure. Did they talk about any lymph nodes? Because generally, if there is a big lymph node in the mediastinal in that paratracheal somewhere area, then that can sort of compress on the recurrent laryngeal nerve. And that could affect, but I think the surgical oncologist would be the best person to comment on.
I think we don't have a surgical oncologist to comment on this. So definitely when we say some kind of a hoarseness, I think we would look at either a lymph node involvement or, maybe the tracheoesophageal groove being involved. Maybe that is there. So definitely the local therapy, once we are able to have a good reduction, I think there may be kind of changes in the surgical take. So the reasonable approach, as we were discussing, it's 2 to 3 cycles of trastuzumab with pembro and Folfox and Capox, and liver lesion. And once it resolves, you'll have a multidisciplinary approach, and we may, consolidate on SBRT. Karthik didn't mention about it, but we may actually want to have an SBRT also, if possible, and alongside of the continuation of the systemic treatment. Now let's go to gastric cancer. So this is a 34-year-old woman who had an epigastric discomfort for 3 months, who had a kg unintentional weight loss, who has been attributing to some kind of a functional dyspepsia, has been on empirical proton pump inhibitor, and family history of stomach is very, very strong, where mother died of stomach cancer at 45 and maternal aunt had a lobular breast cancer, and patient has no history of smoking or H. pylori. And we see that hemoglobin is 10.2 microcytic hypochromic anemia is present. CA is normal. CA 72.4 is elevated, and albumin is 3.2. Upper GI scopy shows linitis plastica. Multiple biopsies are done. And we see that in the CT, there is gastric wall thickening. PET-CT also demonstrates the same. And the staging lab shows positive malignant cells in the peritoneum. So it upstages to stage 4. So histology is signet ring cell type. HER2 is negative. MMR, MSI is proficient. PD-L1 is CPS score 2, which is very low. And Claudin is positive in this case. So when we did the germline testing, it turns out to be positive for CDH1. So obviously, it confers about 70% lifetime risk of diffuse gastric cancer and 40 to 45% risk for lobular breast cancer. So we would have to initiate the cascade testing, which is offered to the first degree relatives. And we might also have to have, prophylactic surgeries done on these individuals, especially if they are female carriers. And the points of discussion here would be, since it's a positive peritoneal cytology stage 4, it's not definitely a surgical candidate upfront. And it's an index case for us now. So the first line therapy in the systemic setting, what would you, look at? Dr. Srujana, would you want to add something on this?
Ma'am, sorry, missed how much was the PD-L1 positivity for this patient?
CPS 2, low.
Low. It's only 2. Okay. Since it was 2, the benefit of immunotherapy is questionable in this patient. So I would not prefer immunotherapy.
Okay. So, Dr. Sheena, would you act upon the Claudin 18.2, and have you used zolbetuximab? You're muted.
Yeah, ma'am, it is Shaina, just to correct you, sorry.
Okay, Shaina.
Ma'am, yes, like Dr. Srujana mentioned, I would agree with that. And like you have written, zolbetuximab is definitely an option, but no, I have not used it for any of my patients. So I have started doing this test, but I don't have the experience of using this drug.
All right, okay. And the fertility preservation counseling is very time sensitive, 34 years. So we have to advocate, especially because it's a female. And what would you actually advocate in this kind of a patient, Dr. Srujana? Dr. Srujana? How do you want to take Shaina?
So, ma'am, I feel that yes, fertility preservation in young cancer patients is always very crucial, but in female patients, it's a little difficult because oocyte preservation takes its own time. We can start with GnRH injections along with chemo, but doing an oocyte preservation, especially in a stage 4 disease positive peritoneal cytology, I think it would take a lot of time. So it needs to be a very detailed counseling with the patient about the pros and cons of doing this and every before starting the treatment. So that's what I do in my OPD for these patients.
Yeah, that's true. And more so having a very advanced stage, it's a very tricky and a very difficult conversation to begin with in the first place, actually. So the regional approach, as you all said, it would be a backbone of chemotherapy. And if logistics is not an issue, then zolbetuximab can be added in this case. If CPS turns out higher, then we might want to actually have an immunotherapy. If the claudin is also high and immunotherapy is higher, we might use zolbetuximab first, followed by that. Later, we may give immunotherapy. So that's about it for this particular case. But for Dr. Karthik, would you think that in case she starts getting, hematemesis and she starts becoming, she starts bleeding, would you want to use hemostatic RT? What will be a fractionation?
Yes, ma'am. So here the only role will be when there is a palliation or for hemostatic RT when there's hematemesis. So depending on the size of the growth, and we can either go for 20 gray in 5 fractions, which is a very hemostatic dose, or if the size is huge, then better to fractionate it for 10 days.
Right. Okay. Thank you. So we'll go quickly to pancreatic cancer. This is a 39-year-old man with a painless jaundice. He lost 5 kilos. He had a new onset of hyperglycemia. He's got a very strong family history of father with pancreatic cancer, paternal aunt with ovarian cancer, and it basically suggests hereditary breast ovarian cancer syndrome. His CA 19.9 is 680, HbA1c 7.8. Bilirubin is 12. Basically, he's jaundiced and he's got a borderline resectable lesion with SMB involvement less than 180 degrees. In the MRCP, there is a double duct sign. And what is done is, in order to alleviate the jaundice, ERCP with metal stenting is done. And we see that in the histology, it is ductal adenocarcinoma. NGS is done. Somatic NGS shows KRAS wild type and TP53 is mutated. Germline testing was done. BRCA2 mutation is present. Now, I would like Dr. Shaina, could you just let me know, in this borderline resectable BRCA2 positive fit 39-year-old patient, how would you approach?
So, ma'am, in this patient, we could use the FOLFIRINOX also, but in a BRCA mutant, the guidelines also recommend the use of platinum-based cisplatin plus gemcitabine also in these group of patients. So he's a young patient and fit, and now I hope the bilirubin level should be come down to less than 3 for us to start the systemic therapy, and then I could take a decision. I'm not sure if there is a direct comparison between the response rates. I would prefer to go for FOLFIRINOX and use one of the PARP inhibitors as maintenance, because it's a borderline resectable. We want the maximum response and want him to undergo surgery.
Okay, actually, Dr. Srujana, see, the POLO study that we have for maintenance olaparib is for metastatic setting, when we have exposed the patient to, say, 14 weeks of, platinum therapy and the response is present. Now, there's not an inkling of understanding about the usage of olaparib in a BRCA2 positive pancreatic cancer in a neoadjuvant setting or in an adjuvant setting. So we don't have data for it. So how will you use this in this particular case?
Yes, ma'am. We have the data for clearly in the metastatic setting. So after the disease has responded, we would give for a BRCA mutant patient an olaparib. But in this borderline resectable patient, because of lack of yet a phase 3 study in this setting, I'll not be using olaparib and I'll reserve it for the metastatic setting.
I think over a period of time, we'll have to just wait for this to be extrapolated for neoadjuvant and adjuvant as well. And what's your take on nal-irinotecan in this setting? I know it's approved for metastatic in the first line as well as in the second line and after. But I believe there is some data for borderline resectable cases also. What's your take on that? Dr. Srujana can take it also.
No, ma'am. I'm not comfortable in giving nal-irinotecan in this setting.
Okay, Dr. Shaina? You're muted.
We have data like you mentioned, but ma'am, I feel in our setting, cost is always a factor. The cost of treatment is all much more when we have to use Nalarifox, and I would prefer. I don't usually do that in my practice. I've used it for a couple of patients in subsequent line, not in the first.
All right. So how many cycles would you advocate for, as in the neoadjuvant setup?
As our clinical practice, what I do is 4 cycles, do a reassessment scan, get an opinion from the surgeon. Every 4 cycles, I would reassess the patient.
All right. I think we have discussed reasonably on the options that are available, and we'll also have to go in for the genetic counseling and cascade and fertility preservation. Again, it's a very, very, very tricky and a very difficult conversation to take forward, especially in this kind of cases, right? So let's go into hepatocellular carcinoma quickly. It's a 32-year-old lamellar hepatocellular carcinoma. Patient had a palpable mass and no infection, no risk factors whatsoever. LFT is normal, AFP is normal, and the patient had no CLD, no signs whatsoever. And what happened is there is a contrast CT and MRI taken, and the central scar with delayed enhancement, had picked up the fibrolamellar HCC. Actually, it could have been missed out very easily because it mimics a focal nodular hyperplasia, but somehow, it was picked up. And AFP is also normal. So remember, she has no risk factors, and the molecular driver mutation is present. The DNAG-B1 PRKA-CA fusion transcript is present. So basically, we see this fibrolamella in adolescents and young adults, and it has no underlying liver disease. So how will you approach this case? We know we have a very good data for Atezolizumab in, conventional hepatocellular carcinoma. But in a case like this, how would you approach? Dr. Shaina? You're muted.
Ma'am, sorry, I'm really sorry. What is the stage, ma'am? Can you just repeat that again? What is the extent of disease?
This patient has got local regional lymph nodes, and basically it looks like it is a resectable disease.
Okay. So means it's a resectable disease in term, it's limited to one lobe. I think fibrolamellar HCC in a young patient, I think would have, I'm not sure if any of our trials included fibrolamellar HCC.
No,
Any
I
of
don't
the
think so.
systemic therapy
I don't
trials,
think so.
Yeah, they are only for the conventional. I think surgery could be offered to this patient. I'm not very sure. Not had a case of fibrolamellar HCC, frankly.
Okay. How about Dr. Srujna?
Ma'am, 2 minutes left for the session.
Okay. Yes, ma'am. Even though we have no data, but we have no option but to extrapolate it and treat it as the conventional HCC related to cirrhosis only. So in this case, a young patient with resectable disease, either surgical resection or a liver transplant could be also an option for her.
Yeah, I think there is some extrapolated data that we could also be using Atezolizumab in certain cases when it is like, inoperable and stuff like that. So that's what I was about to come to. So let's go quickly to colorectal cancer. So I'm not sure if I'll be able to go through this, but anyway, a quick point here is that this is a 36-year-old patient who had a rectal bleeding, and normally we just think of hemorrhoids, and a lot of people neglect it, and later it becomes very advanced. So this patient also had a stage 4 with the liver mets, and germline testing was done. It's Lynch syndrome. So basically, what would you have? I mean, it's a straightforward case. It's a no-brainer. So Dr. Shaina, quickly.
Yeah, so I think they've had a good discussion in the previous slides also about the dual IO in MSI high metastatic colorectal cancers, and that's what I would follow for this patient.
Yes, I think that's the way to go. And Dr. Strujna, would you add anything to this? Suppose, for example, you have dostarlimab also with you. I mean, we don't have a guided thing in the NCCN. It's not yet incorporated. But would you be tempted to use dostarlimab is one question. And the next is, if you get a very good response, would you go for a watch and wait? Instead of doing a surgery, would you watch and wait?
Yes, ma'am, because she's a young patient and with MSI positive tumors having excellent response to immunotherapy, we can still watch and wait in these patients and explore the surgical option once they progress.
Very good. And sperm banking, again, is something which we have to definitely do just before pelvic radiation. So, Karthik, what is your take on this?
Yes, ma'am, right. As the options were discussed, so we would go ahead with the systemic therapy. And here, young patient in rectal malignancies along with the solitary mets, it's better to consider, if not watch and wait, if it progresses, then surgical option would be considered first as a local therapy. So radiation would be deferred until when it is really necessary in this patient.
Sure. So, would you like to add anything, Dr. Shana?
No, I think, ma'am, when it comes to watch and wait approach, it's very important to have a compliant patient to know what is the
100%.
Yes, so I mean, what are the follow-ups that they need to come for? Because that is very crucial, especially in offering it in a younger patient. I think that needs to have a very detailed discussion.
Sure. Thank you very much, Dr. Shana, Dr. Strujana, and Dr. Karthik, and the IAIO team. I'm logging out now.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am. As
Thank
we
you.
conclude today's session, I would like to sincerely thank you to our program director and our esteemed faculty members for sharing their outstanding knowledge and clinical expertise. I also extend my heartfelt thanks to all the participants for joining us and making today's program interactive and successful. On behalf of IAIO, thank you for being with us. Have a wonderful evening, stay safe, and we look forward to welcome you to our upcoming IAIO academic programs. Thank you. Good night, everyone.
You and good night.